Very good morning to all. At the outset, I would like to thank the organizing committee and the chairpersons for preponing my talk because I have a flight to catch, so sorry about that. And though it is slightly out of the topic, this topic is basically the surgeons has to be awake after spine surgery. So it's a 30-year-old male with severe low back ache for 2 months, radiating to right lower limb with numbness over the right foot, tenderness over L4-5, SLRT right side it's 30 degree, neurologically is near normal. So this is the MRI image. So whenever we see this image, the immediate thought in our mind is, okay, the patient requires surgery, no relief with conservative treatment. So what type of surgery? Endoscopy, transforaminal, interlaminar. But actually, how many of us elicit the history of sexual function of this patient? Actually, if you practically see, it is not even 1% of us, we elicit the proper sexual history of the function, and we don't discuss anything about the sexual rehabilitation for this patient. So with this background, I'll be discussing about the sexual aspects after spine surgery. So it is, though it is one of the most passionate topics and passionate thing for all of us, it still remains a big taboo amongst our society, and we rarely discuss about these aspects to our patients. So just a few slides about the basic anatomy. This is a study which was done in rats, and they say that there is a center called a spinal generator of ejaculation, and ejaculation has two aspects, emission and expulsion. The sympathetic and parasympathetic centers are responsible for emission, whereas the somatic centers are responsible for expulsion and to prevent retrograde ejaculation. Again, according to this study, they classified into the lesions being, the thoracolumbar levels being infralesional, or if it is lesional, or it is completely involved in the lesion. So the ejaculation rate was 0% in patients with complete lesions involving T12 to S5 segments, according to this paper, whereas 90% ejaculation rate could be seen when these segments, T12 to S5 segments, were infralesional. Suppose if you are having a lesion at T9 or T10s, even then 95% of these patients will be able to ejaculate. So coming to the epidemiology, we all know that sexual function is an important determinant of quality of life, but however, the disease itself or the surgical approach, the fusion modalities or the neurological function can be affected after spine surgery, and we have to discuss about this overall impact to the patient and their attenders in detail. It could be affected because of the neural compression per se or because of the pain, and back pain has worse effects on sexual activity than neck pain, and more than 2/3 of the patients have sexual dysfunction when they present. According to this survey, which was conducted in 2008, 72% of sexually active respondents had less sex compared to before their back pain. Similarly, 60% indicated that back pain had made their relationship worse with their partners. And 52% of the respondents said that they had not discussed because the doctor did not come forward to discuss or raise this issue with the patients. So coming to a few facts, the incidence of erectile dysfunction in patients less than 50 years with lumbar spine disease without any other comorbidities is about 34%. That is 1 in 3 patients with lumbar spine disease without other risk factors can be affected by lumbar disc disease. Now, does sexual function improve after surgical treatment? Because already patients are very scared that after spine surgery they will not be able to walk. But when it comes to sexual function, definitely they'll have their doubt, and it is very clearly shown by various trials and according to the sports study, operative treatment leads to improved sex life related pain. The pain after surgery has dramatically decreased in these patients. But however, despite significant improvement in VAS, ODA and NS, there was not much improvement in the ED status. And patients with a NAS score of greater than 70 postoperatively, they are likely to have ED postoperatively, which means that it could be because of the nerve damage, because of the pathology itself. So if the patient is having erectile dysfunction, it is better to discuss with the patients preoperatively that erectile dysfunction could be because of pain or it could be because of the disease process itself. Now the next question is, does sexual function differ between surgical methods? So there are various types of surgeries, and all the studies have shown decreased sexual desire and erectile dysfunction in these lumbar stenosis or lumbar disc prolapse patients, and most of these studies were conducted in patients with lumbar disc prolapse. After surgery, the frequency of intercourse increased while any type of sexual problem actually decreased. And surgery improved sexual desire and frequency of sexual activity in about 80 to 90% of the patients. And the sexual activity was resumed within 2 weeks in about 23 patients and about 50% in 4 weeks. Now, as per literature, it says posterior surgery is better than anterior surgery when it comes to sexual related outcomes. But however, there are no studies or no randomized studies which compares open procedure versus MIS procedures. And regarding anterior procedure, we all know that open procedure is associated with significant higher risk of retrograde ejaculation, and even it is seen in transperitoneal approaches about 10 to 15% of the patients. And again, this study showed that 26% of all men in the fusion group compared with 3% in disc replacement group reported postoperative deterioration, and they say that disc replacement is slightly better compared to fusion procedures for sexual related outcome. So we did this study, and in 51 patients who underwent microdiscectomy as well as MIS TLIF, and the mean age was around 34 in males and 32 in females. We used the following scores, and along with that we used the questions which included favorable position, masturbation, and the time of commencement of sex after surgery. So this is the improvement of sexual function postoperatively. It was clearly improved, and resuming sexual activities, around 50% of the males resumed their activities within 2 weeks. Both in males and females, they resumed their activities within 2 weeks, and most of them resumed within a month. But the main thing is, they said it is the fear and anxiety because of which they were not able to have sexual intercourse. Coming to resuming masturbation, surprisingly, none of the patients resumed masturbation. Even if they resumed, they had decreased frequency and earlier ejaculation less than a month. Whereas in females, about 50% started within a month, and around 40% achieved orgasm through masturbation, and 90% of them had pain while masturbation. But however, when we actually discussed with the patients, when we counseled the patients, the female patients were actually willing for early sexual intercourse, but it was the partner's anxiety and fear that they were not able to undergo. And the commonest position among males is standing position, whereas it was in females it was missionary position which they usually followed, and that actually had less pain. So with this, the preferred sexual position for males is face-to-face position with the pillow underneath the back in these patients. And for female patients, it is kneeling position. There is a recent article which was published in 2019 which showed various coital positions related to back pain, and missionary position with a pillow on the back is also a recommended one. So the take-home message is sexual function is an integral part of our treatment. The taboo and myths about sex has to be broken. And fear and inhibition is the major roadblock, not only in our population, even in the so-called Western population where they talk about everything so frankly. And proper counseling is mandatory before and after surgery. Thank you.